Hello, my name is Karen Goodwoolley, and I'm a clinical nurse educator for Peace Health Southwest Washington. I am working together with the Rebound Neurosurgery Group to bring you this virtual class. If you have a support person already identified, please let them join you now. Make yourself comfortable and grab some paper and something to write with so you can jot down any questions as we go through this information. Should you have any questions after today's class, please contact your provider at Rebound Neurosurgery. The phone number will be at the end of the presentation. You will also receive additional information about your surgery from the surgeon's office. The goals for this presentation are to give you a general overview of spine surgeries and what to expect with the process. I will go over both neck or the cervical procedures and the lower back or lumbar procedures and include a few videos that will help illustrate how they are done. I will also cover the role of the support person or coach, spine anatomy, how to prepare for surgery, and what to expect on the surgery day and during your hospital stay if you are staying, pain medication, and pain expectations. Another very important part of preparing for surgery is identifying a support person or coach who can be there to support you through this journey. That person should be a friend or family member who is actively involved with you. This person should be able to stay with you the first night of surgery, sometimes longer depending on your surgery or your health. And that person is vital to your recovery process and will be your biggest cheerleader. We want him or her actively engaged in your recovery by helping you with things around the house, assisting you with your exercises, offering reassurance, and just being there for your safety. And that person, again, should stay with you the night of surgery, and you may need help a little longer, depending on how you are doing or the type of surgery you had. That support person is there to provide comfort and motivation, as it is crucial for your healing. Now let's cover a little anatomy. The spine is made up of many bones called vertebrae, and these vertebrae are grouped into four main sections in the spine. We have the cervical spine or the neck region, the thoracic spine or the chest or upper back region, and the lumbar spine or the lower back region. Then there's the sacrum towards the tailbone and the coccyx at the very end of the spine, and that is your tailbone. Elective spine surgery is most commonly done in the cervical and the lumbar regions, as these areas are more vulnerable to injury over time. The thoracic spine is fairly well supported by the rib cage. A few more areas of the spine. Here's a few models just to kind of pull the pieces apart and explain them to you. On the far right is a model of the spine, and next to it, a few vertebrae are showing a foramen or a bony hole where the spinal nerve exits off that spinal canal. The upper left is a side view model of a single spine segment called a vertebra. Below that is the top view of that same vertebra showing the hole or the vertebral foramen where the spinal cord passes through. The two flat bones at the bottom or the back side of this bone are called lamina, and the bony process in the middle is called the spinous process, and those are the bumpy bones you feel down your back. The model in the middle is a picture of the intervertebral disc as it lies next to the spinal cord, and the spinal nerves as they branch off the spinal cord. These spinal nerves go through those openings or foramen on the sides between the vertebral bodies as they are stacked in your body. And these discs cushion and support the space between each of those vertebral bodies. The tough outer layer of the disc is called the annulus fibrosus, and the inner soft part is called the nucleus pulposus. These discs are between the bones and give that foramen space for the spinal nerves to pass through. Also along the spine are blood vessels, ligaments, and muscles supporting it. Now I want to cover a few spine conditions that may require you to have surgery. There are many reasons spine surgery may be done, which is why spine surgeries are very individualized. Here are some examples of some conditions that can affect the intervertebral discs. At the top for your reference is a normal disc, plump and hydrated, and it serves as a cushion between those bony vertebral bodies. Each disc absorbs the stress and the shock of the body that it occurs during movement and prevents the vertebrae from grinding against one another. The discs, again, have a tough outer layer, and that's called as annulus fibrosus, and that soft intersection called the nucleus pulposus. It's similar to a tough jelly donut. So moving down, you'll see the disc, and they call that disc degeneration, caused from dehydration of the disc, and it can occur with time and age. And then you can get compression of the spine and cause pain if this happens. You can have a bulging disc. That's where the cartilage dehydration and stiffening leads to the cartilage bulging out from its intended location inside. And the bulging material can press on the spinal cord or the nerves, leading to symptoms like numbness, tingling, shooting pain, weakness, for example. And then moving down, a herniated disc, also known as a ruptured disc or slip disc, the cartilage cracks and allows that jelly-like substance to protrude from the disc. That herniated material can press on the spinal cord or nerves, leading to similar symptoms: numbness, tingling, shooting pain, and weakness. You could get a thinning disc, and that occurs with age, dehydration, and may be the reason why people shrink with age, and it can cause compression on the spine and cause pain. You can have disc degeneration with osteophyte formation or bone spurs. The body builds excess bone to help stabilize the region with an unstable disc, and the bone spurs can press on the spinal cord or the nerves, leading to those symptoms again: numbness, tingling, shooting pain, and weakness. And then another condition not pictured here is called spondylolisthesis, where the spine is not quite aligned, and this is caused by spondylosis, a natural degeneration of the spine. Misalignment can cause chronic pain and limited mobility. There are some other conditions that may require surgery, such as tumors or abscesses, but they are not as common, so they're not going to be covered here. Now I'm going to talk about a few procedures. The first procedure is called a laminectomy, and that's used to treat spinal stenosis. Stenosis is when the spinal canal narrows, pinching the spinal cord and nerves. With a laminectomy, they remove the bone or the lamina to widen the canal, removing pressure from this nerve. Now I'm going to show you an animated video to help demonstrate this. This is the first of about 4, and if it does not apply to you, please just feel free to skip over it.
A lumbar laminectomy is typically performed to alleviate pain from lumbar spinal stenosis. Spinal stenosis is caused by degenerative changes that lead to enlargement of the facet joints in the back of the vertebrae. The enlarged joints and related degenerative changes place pressure on the nerve roots as they exit the spine. Each vertebra has 2 portions of vertebral bone over the nerve roots in the back of the spine. These small flat bones are called the lamina. The lamina functions as a protective covering of the spinal canal. In the lower back, they protect the cauda equina, the nerve roots that branch off of the spinal cord, as well as the nerve roots as they exit the spine. Removing all or part of the lamina through a lumbar laminectomy can give the affective nerve root more space and a better healing environment. In a laminectomy surgery, the spine is approached through a 2 to 5 inch incision in the midline of the lower back. Next, the left and right back muscles, called erector spinae, are dissected off the lamina on both sides and at multiple levels. After the spine is approached, the lamina is removed, allowing visualization of the nerve roots. The facet joints, which are directly over the nerve roots, may then be undercut or trimmed to give the nerve roots more room. After the surgeon has confirmed that all pressure has been removed from the nerve, the paraspinal muscles are sewn back together to cover the laminectomy site. After the lamina and any other sources of pressure on the nerve roots are removed, the nerve roots have room to heal.
The next surgery I'm going to talk about is a discectomy. The discectomy is the removal of herniated or bulging disc material to take the pressure off the nerve. This can be done a couple of different ways, and your surgeon will discuss how this will be done in your particular case. It depends on many factors, including the condition and location. Now let's watch another animated video to help demonstrate this.
Lumbar disc microsurgery. This minimally invasive procedure relieves pressure on nerve roots caused by a herniated disc. It can eliminate the pain of sciatica. In preparation for the procedure, you are anesthetized. The surgeon creates a small incision in the skin of your back. The muscles and tissues are pushed aside to allow access to your spine. The surgeon creates a small window in the lamina. This is a portion of vertebral bone that covers your spinal canal. The surgeon places instruments through this window. The spinal nerves are gently moved aside, and the surgeon clears away the herniated portion of the vertebral disc. This relieves painful pressure on the nerves. The rest of the disc is left in place, where it will continue to cushion the vertebrae. When the procedure is complete, the instruments are removed and the incision is closed. Your surgeon will give you specific instructions to help you recover.
The next procedure to discuss is a fusion. This is the removal of a disc and the replacement with graft material, and this creates a bridge between two or more of the vertebrae. And now let's watch a video demonstrating this.
TLIF, transforaminal lumbar interbody fusion. TLIF is generally used to treat back or leg pain caused by degenerative disc disease. The surgeon will stabilize the spine by fusing vertebrae together with bone graft material. The procedure is performed through one or more small incisions in the back. Parts of the vertebral bone need to be removed to get access to the disc. Since most TLIF procedures access the disc through only one side of the spine, recovery time after the procedure will be shorter than with traditional fusion surgery. The damaged disc is partially removed. Some of the disc wall is left behind to help contain the bone graft material. The implant is placed in the empty disc space, realigning the vertebral bones. This also lifts pressure from pinched nerve roots. The area may also be filled with morselized bone. The surgeon may implant a series of screws and rods for additional support. Bone graft is also placed along the sides of the spine. The morselized bone graft will grow through and around the implants, forming a bone bridge that connects the vertebral bodies above and below. This solid bone bridge is called a fusion.
The last of the procedures will be the cervical procedures, and these are performed in the upper spine or the neck area. They may or may not have hardware inside, for instance, a fusion or an artificial disc, or they may focus on relieving pressure where the procedure would be a laminectomy or some disc removal. Now I have a little video for you to watch on this one. And again, if it doesn't apply to you, please pass it and continue on with the lesson.
Anterior cervical discectomy and fusion. This surgery removes a herniated or degenerative vertebral disc in your neck and replaces it with a bone graft. This can relieve painful pressure on spinal nerves. In preparation for the procedure, you are positioned on your back. You are anesthetized. The surgeon creates a small incision in the front of your neck. The structures within your neck are gently moved aside to create a path to your spine. The surgeon carefully removes the damaged disc. This leaves a space between the vertebrae. The surgeon inserts a bone graft into this space. The graft fills the open space. It holds the vertebrae in the proper position. The surgeon may secure the graft with a metal plate and screws. When the procedure is complete, the incision is closed. As your spine heals, new bone will grow. The graft will become permanently attached to the vertebrae. This is called a fusion.
Here's a couple examples of what the instrumentation may look like. On the left is cervical, and there's a picture of a cervical plate over there on the left. And on the right is a picture of some instrumentation of pedicle screws and rods for a lumbar fusion. Now let's talk about preparing for surgery. In preparing for surgery, there are some important points I would like to cover. We want you in the best health possible before surgery, so gaining some knowledge about what to expect is very important. Staying active and eating well. Fruits and vegetables offer many vitamins, including vitamin C, and meat, fish, beans, and legumes offer protein, which are all important for healing after surgery. We want you to drink fluids to stay hydrated. It's important before surgery, so when the nurse starts the IV for the medications that you receive during surgery, your veins are nice and plump. This is also very important for a healthy spine. We want you to stop nicotine use. It does interfere with healing, and if you need help with this, please contact your provider. Avoiding constipation. We will discuss more on this later. But we do want you to manage any other health conditions such as diabetes or high blood sugars and high blood pressure or hypertension, as these problems can interfere with your healing and put you at risk for bleeding or even a stroke. Now let's talk about preparing your home for surgery. We want you to be safe at home. So make sure you have clear walkways. Ensure you can walk safely in your home and remove any loose rugs or electrical cords that might be crossing paths. Ensure you have proper lighting. If you need to put up night lights, please put them up. You may want to move frequently used items to waist level on the counter. Pots and pans in the kitchen, for instance, toiletries or any clothing you might be wanting to wear. Put them up on the dresser so you don't have to go into your drawers, just temporarily. Make sure there are clean sheets on your bed and that your home is clean for after surgery in particular. You may want to do some meal planning and freeze some meals ahead of time so you won't have to spend a lot of time in the kitchen cooking if you don't have your coach or support person there to help you. Please make arrangements for your pet care if you have one or more, so you don't have to worry about that pet during your surgery. And also remember that pets can tug on leashes, so if you need to walk your pet, you may need assistance with this for a while. Also, no sleeping with pets the night before surgery and after surgery until your incision is completely healed. If you need to bend over to feed or water your pet, you can bend. You just want to remember to keep your back straight and bend at the hips and the knees. If you need to take care of a kitty litter box, again, bend carefully when you're doing this and be meticulous about washing your hands after you do this. Now I'm going to talk about your pre-op appointments. Now, in changing times, some appointments are going to be done over the phone or by telemedicine, and not all appointments and tests will need to be done by everyone. Everyone will need to be cleared for surgery, and that will be done in a variety of ways. Some may need tests or lab work, and the neurosurgery office will let you know exactly what you need. The surgeon will review the procedure and your risks, and you will have to sign a consent. And they'll also validate medications that you need to take on the morning of surgery. Anywhere from 2 weeks before surgery until the day before surgery, a pre-op nurse will call you to gather some information. During this call, the nurse will verify your health information, your health history, and current medication list. They will need to know all of your medications you are taking, including over-the-counter, any herbal and prescription medications, how much you take, and when you take them. Please get this organized beforehand, as it will make the call a little easier on you. And if you do not receive this phone call, it's okay. They will gather this information after you check in for your surgery. The week before surgery, please call the surgeon's office if you have any of the following symptoms. For instance, any symptoms of illness like a cold, a cough, fever, or flu-like symptoms, changes to your skin such as a rash. We do want to remind you not to shave near that surgical site for 2 days before surgery. This is particularly important for the cervical or neck surgeries. We want people not to shave their neck. We clip in the hospital, and small cuts caused from shaving can put you at risk for an infection. So please do not shave for 2 days before surgery. If you have any questions or concerns, please give the office a call. The day before surgery, you will be called sometime around 5 or after the night before to confirm your surgery time and when you should arrive at the hospital. If you're having surgery on a Monday, you will receive this call on a Friday. We want you to shower with an antimicrobial soap, and I'll talk more about that in a few slides. We want you sleeping on clean sheets and wearing clean pajamas and no pets. We don't want you to have anything to eat or drink after midnight. That includes gum, mints, water, and hard candy. And I will cover a little bit of that in detail coming up. Bowel care. Ensure it's been no more than 1 or 2 days since your last bowel movement. So showering with an antimicrobial soap before surgery. You can buy an antimicrobial or germ-killing soap over the counter like Dial, Safeguard, or HIPAA-Cleanse. What we want you to do is wet your body, get in the shower, wet your body, then turn the water off and lather up with a generous amount of soap. Include your back, so get either your coach or a back scrubber to wash your back. Avoid using the HIPAA-Cleanse in your genital area. You can just use regular soap. So this is from your neck down. We want you to have that soap in contact with your skin for a few minutes and then rinse it off. Feel free to wash your face and your hair with normal soap and or shampoo. Now remember, I did say do not eat or drink anything. Some particulars that I can go over. These are some common questions I'd like to cover. Can I eat before my surgery? So the night before your surgery, you can eat a normal meal. Do not eat or chew anything after 12 p.m. midnight. This includes the food, gum, mints, or alcohol products. Now, what to bring to the hospital? So when you are going to come for surgery, please bring the following items. If you're not staying overnight, please bring eyewear, hearing aids, dentures, and supplies for these items. Your clean and comfortable clothing, probably what you wore to the hospital. Comfortable non-slip shoes or nice sturdy slippers. And if you have a walker or cane, please bring that. We can label it when you get here. If you have an advance directive or a PULSE, which is a physician order for life-sustaining treatment, or any power of attorney documents, and you want those in your charts, please bring a copy of those. Information and paperwork from the surgeon's office is also very important to bring. If you are staying overnight, please bring the above items in addition to an extra set of clothes. If you have a CPAP machine, that's for sleep apnea, you're allowed to bring that with a clean mask and clean tubing. You can bring any toiletries or other personal items you think you might need. And please bring a charger for your devices if you wish to charge them. And please label these items if you can. We do want you to please remove all jewelry and leave your valuables and all medications at home. Thank you. Now I'd like to help explain where to go for your procedure. Please arrive about 2 hours before your surgery. The night before your surgery, you will be told exactly what time to be there. The locations are going to be the Furstenberg Tower on the 2nd floor, and this is the tallest building on our campus. Those doors do not get unlocked until about 5 a.m., so please be aware of that. Or if you're having surgery at the Surgery Center or the ASC, that's in the 2nd floor of the Physician's Pavilion, and that's next to the parking garage. Those doors do not get unlocked till about 5:45 a.m. I'd like to talk to you about some things to know about being in the hospital, and that's if you are staying with us over a night or two. For your safety, you will be asked repeated questions. For instance, your name, your date of birth, about your allergies, and about your pain level. When we ask you about pain, so we can better help you manage it. And you may go to surgery earlier or later than you had planned. We do try to stay on schedule, but we do get emergencies, but we will keep you informed. We really do care about you and your hospital experience. There's a couple more things to know. We do wake you at night to check your vital signs and make sure you are safe. We will ask you to dress in your own comfortable clothes each morning to get you up and walk you around the halls. And we will ask you to be up in your chair for all of your meals. And we also will ask you not to get up without somebody assisting you. You are not in your home, you are in an unfamiliar place, and you might be on some pain medicine. So we really want you to be safe. So ask for help, please. So when you arrive for surgery, you're going to arrive in the pre-op area. You will arrive on the second floor of either the pavilion or the hospital, and then you will check in and get registered. So then the staff will assist you with changing into a hospital gown. They'll check your vital signs, your heart rate, your blood pressure, and your breathing, and possibly a blood sugar. The RN will start an IV in your arm or hand, and that's for antibiotics and medicine. The surgeon at some point will come in and mark your surgery site, and then they may prep it ahead of time. You'll meet your OR team, and this is usually done just before you head off to surgery. And that's when your family, if your family is able to come in, will be asked to leave and go wait for you in the waiting area. The next person you would meet before you go to the operating room is to meet your anesthesiologist. The anesthesiologist will cover your health history and medication history. For instance, have you had any trouble with anesthesia before? They'll discuss any nausea or pain management concerns you might have, and what type of anesthesia you will have. This is the best time for you to ask any last-minute questions. So the surgery time, this is when the operating room nurse will come in and verify your information and take you back to the OR. Your friends and family can use the electronic screens shown in the next slides to monitor your progress with a number given to them. And the receptionist in the waiting area is there to answer any questions for them. And remember, the actual surgical time may vary. The PCell Southwest waiting room. If permitted, your support person or coach or friends and family can wait and follow your progress from pre-op to recovery in this manner. There is a board up on the upper right-hand corner. It's a big television screen, and on it are a variety of numbers and colors. The number is specific to you. There's no personal information up there, but the colors on the screen indicate where you are in the progress. For instance, the teal colored shows that this patient is in the recovery area, or the PACU. The recovery room, or that PACU or PACU, you can expect to be there for about 1 to 2 hours. And this is where the RNs will closely monitor your vital signs. Your heart rate, again, your blood pressure, and your breathing. They'll check your neuromuscular status by asking you to wiggle your fingers and toes and ask you about pain, numbness, tingling. And they're there to treat your pain. And if you have any nausea, they'll treat that as well. Now let's talk a little bit about post-op discomfort. I want to warn you that the goal for your surgery is to decrease your pain probably by about half. Please do not expect to be pain-free immediately. You will probably have some remaining nerve symptoms, and those are like pain, numbness, tingling, weakness. These take many months sometimes to resolve after surgery. The nerves take a long time to heal. You will have an incision site, so expect some soreness or pressure there. Some patients may even have a drain. You may have some swelling and bruising, and that's normal. You did get an incision, and that may feel like tightness around the incision. Now I'd like to talk a little bit about the pain scale. Some people have seen this before and are familiar, and others maybe not. So the pain scale that we use typically goes from 0 to 10, 0 being absolutely no pain, and 10 being the worst possible pain you can imagine. So at 0, no pain. At 4, you're still okay. Above 4, this level of discomfort prevents you from sleeping, having a decent conversation, and very importantly, it prevents you from wanting to move and walk. So we try to keep the pain level down below the 4 or 4 and below. On the far right, you can see some faces. If the faces make more sense to you, you can and identify with those. You can use those and point to the face that expresses your pain level. So we do this so we can accurately medicate you. We don't want to give you too much medicine, and we don't want to give you too little medicine. So being accurate with the number helps us choose the proper medicine and the proper amount of medicine. Now let's talk about a few spine precautions, and we call them BLTs. So that's bending, lifting, and twisting. So you can bend, but we want you to do it as instructed by the surgeon, the nurse practitioner, or the physician assistant, and the nurses at the bedside. So you may bend slightly using good body mechanics, and we want you to stop if you feel it pulling on the incision site or you have pain. You may lift up to 10 pounds with both hands or 5 pounds in one hand. You can have slight twisting motions when you need to. For example, when you're using the toilet, you can wipe yourself, putting on your shoes, putting on your socks, but we really want you to be conscious and protective of your spine after surgery. If you have precautions other than what's listed, you'll be educated to this prior to your discharge, but we always want you to follow your provider's recommendation. So remember, good posture, good body mechanics, and listening to your body are all very important to your recovery. Let's talk about some surgery day goals. We want you out of bed and walking. We want you resuming your diet, managing your pain, and making sure you're eating your meals up in your chair. The ultimate goal is to be out of bed as much as possible. Rest when you need to, and get up and move, because motion is lotion. When I say motion is lotion, that means moving helps lubricate those joints and makes you feel better ultimately. Now let's talk about your responsibility for pain management. We want you to intercept the pain. Ask for medication when the pain starts to escalate. Please do not wait. We want you to take your pain medication when you feel the pain escalating, for instance, if you're home. Remember to tell the nurse if the medication is not effective. It can take 30 minutes for an IV medication or up to an hour for an oral medication or a pill for it to start working. So we really want you to pay attention when your pain is escalating. Please ask us questions, especially if you don't understand the pain management efforts that are in place or if you have questions about your medicines. That's okay. Please remember that we cannot make your pain go completely away, but we will do all we can to make you more comfortable and keep you safe. So, being discharged from the hospital, we really want you to plan to have your support person at the hospital to hear their discharge teaching. If you have to travel over an hour away, please stop along the way about every hour to get out, stretch, and move around. Otherwise, you'll just get stiff and sore. So please remember, take care of yourself and stop along the way. Now, a little bit more about your medications. After surgery, we're going to have you resume your pre-op medications as you're directed. Make sure you're writing down when and how much pain medication to take. And the goal is when you decide to decrease your pain medication, do it slowly. For example, you can cut the pill in half or increase the amount of time between your doses. Bowel care, we'll talk more about that, but if you need to, you can take stool softeners or Miralax and walk. Walking is wonderful for this. But please call if your pain medication is not working. Take it only as prescribed. Never double up on it. Don't take more than prescribed. And if it's not working, please call your provider. Now let's talk more about managing your pain. Besides pain medication, you can use ice packs. We really do not want you using heat for the first 3 weeks. If you're using it now, that's fine. But after surgery, we really want you to use ice instead because the heat can cause more inflammation. We want you to reposition yourself at least every hour. We want you walking and we want you taking your medications. And you can take acetaminophen or Tylenol as long as you closely follow those directions because there is a limit for how much you can take in a 24-hour period. You may also take NSAIDs or non-steroidal anti-inflammatory drugs, for example, ibuprofen, 3 days after surgery, unless you've had an effusion. Those fusion patients have to wait 3 months before taking the anti-inflammatories. It does interfere with your bone healing, so we really don't want you taking those for 3 months. Remember to take the narcotic pain medication when you need it, listen to your body, but you can use Tylenol in addition to your pain medication that's prescribed, but you may want to alternate it, and that is called multimodal medication when you can not use just one type of medicine. Now let's talk a little bit about ice pack options. You can also get a copy of these ice pack options from the surgeon's office. For instance, there's a home ice pack. This is one of my favorites. You just had 2 parts water and 1 part rubbing alcohol, and you combine them, put them in a Ziploc bag, and then double that to protect your clothes and furniture. So make sure they're in 2 bags. Place it in the freezer until it's slushy, and then you can keep your ice on your skin. Make sure you have a protective layer between the ice and your skin, and keep it on about 15 minutes at a time, every hour for pain relief. The unpopped popcorn is another option. The popcorn kernels are really dense, so they stay cold longer than the frozen vegetable options. Then you can have gel packs, and you can purchase gel packs at a variety of stores, or you could use liquid fabric softener or dish soap or even corn syrup in a Ziploc baggie and freeze that overnight. And you can use salt and water. Just 2 tablespoons of salt to 2 cups of water and put them again in a Ziploc freezer bag. Now we're going to cover preventing post-op complications. These complications are rare, however, I do want to cover them so you can be prepared to avoid them. So, to prevent blood clots or a pulmonary embolism, which is a blood clot to your lung, we recommend ankle pumps and frequent walking. And ankle pumps are just moving your feet back and forth. And to prevent pneumonia, you can simply cough and deep breathe, or if you have one of these incentive spirometers, which is over on the right-hand side, you can use that. And that's taking deep breaths, bringing that baffle up to a level, and do 10 breaths a minute every hour while you're awake. 10 nice deep breaths, and walking. And you should begin doing these exercises while you're in the hospital so we can help if you have any questions. Another complication we want you to avoid is constipation. Preventing constipation includes using stool softeners, staying hydrated, and eating a nutritious diet, for instance, fruits and vegetables, and yes, frequent walking. So if it's been a few days since your last bowel movement, it's okay to try an osmotic laxative such as Miralax. This is not a stimulant laxative. Instead, it increases the amount of water in your intestines to help stimulate a bowel movement. So begin at the top, work your way down. Give the laxative a day to work, and then you could try a suppository or an enema in a day, and then maybe call for help if it is not working. The safest way for bowel health is eating healthy, drinking water, and walking. And then there's a formula I'm sharing here from some nurse colleagues. It's apple and prune juice warmed up with a pat of butter, and that equals relief. Almost done. So when to call the provider? Please feel free to call your provider if you have any questions you need answered, but in particular, if you develop any of these symptoms, we want you to call the provider. difficulty urinating or controlling your bladder, if you have any new arm or leg pain or changes in your sensation, if you have any signs of infection, for instance, redness, swelling, perhaps discolored drainage, a fever, chills, or sweats. If you have watery drainage from the incision, and especially if this is accompanied with a severe headache, it could mean it's a cerebral spinal fluid leak, and you need to identify this and talk to them about possibly getting this treated. If you have shortness of breath, chest pain, or dizziness, signs that you're having a stroke or heart attack, this is an emergency. Please do not hesitate to call 911 or go to the closest emergency department. And remember, this applies if you cannot reach your provider and you feel like you're having an emergency. Please call 911 and seek help. Now I will give you a basic overview of the type of recovery timeline you can expect. Please remember that this timeline can vary depending on your health, your surgery, and other factors. So the first week after surgery, you should walk daily and increase your walking distance and time as you can tolerate it. Walking helps to prevent the post-op complications, and it helps you to resume your normal gait, and it's a great way to stay active. You will not be able to drive during your first week after surgery, and your provider will tell you when you can resume driving. Avoid bending, lifting, and twisting too much. You can lift up to 10 pounds your first week after surgery, about the weight of a gallon of milk. If you feel your incision pulling, though, stop because that's too far. We want you to avoid jarring motions, for instance, motorcycle riding, horseback riding, as well as pushing and pulling motions. It strains your back. On your third day after surgery, you may take your first post-op shower. Before your shower, make sure you remove any gauze dressing that is in place. Do not cover it with plastic and wrap it and tape it. It can get soggy. Please do not remove any of the small tape strips or the medical glue that is on your skin. Just allow these to wash off over time. You can let water, shampoo, and soap run over your incision, but do not soak your incision until it is completely healed, and this can take several weeks. So this includes soaking in the bathtub, hot tub, or pool. So weeks 2 to 4, we want you to continue to walk daily. You should continue to walk and gradually increase the amount of time that you're able to do that. That goes along with lifting, so gradually increase your lifting as your surgeon recommends. And most people resume driving during this period, but your provider will let you know when it's okay to start driving. We don't want you driving if you're taking any prescription pain medications, and that's for your safety and the safety of others. And most people can return to light duty work during this time period, but that's a discussion with your surgeon as well. So your activity during weeks 4 to 6, we want you to continue to walk daily, and you're going to continue this even after week 6, please. And during this time period, you can resume sex when you're comfortable. What we don't want you is to be in pain during sex. And also, most people will return to work between 6 and 12 weeks. This is to full duty work, if you haven't already. And if you have questions about when you can expect to return to work, please ask your surgeon. And here's a screen that shows the Rebound Neurosurgery teams. You may see one of the physician assistants or nurse practitioners at one or more of your visits. These teams work very closely with one another, and feel free to ask any of them any questions. This screen shows you your resources. Rebound Neurosurgery for medical questions or questions about your surgery at 360-256-8584. If you have questions about your hospital stay at PCL Southwest Washington Medical Center, call the charge nurse on the neurology unit or Tower 6 at 360-514-2182. Other questions, feel free to contact the neuroscience clinical nurse educator at 360-514-6105. And those surgical animations that were throughout this presentations can be found at www.reboundmd.com. You will want to look under Patient Resources, Patient Education, Orthopedics, then Spine, then Surgical Care and Management, and that's where those videos will be. There's also information on spineuniverse.com. Thank you for taking the time to listen to this presentation. I hope it helps you understand what you have to do to prepare for surgery and what to expect during and after your procedure. Here are some final reminders. Please make sure you identify your support person. Also, if you jotted down any questions during this presentation, please call the Rebound office at 360-256-8584 and someone will help you get the answers you need. Now, on behalf of the Peace Health Southwest Spine Center team, we wish you a speedy recovery. Please stay safe, wear a mask, and stay socially distant. Thank you very much.